Oscar?
Yes. So, so most of the distributors will see this presentation recorded. I want to say a few things. Today presentations will be focused on kids now that we have the small sizes from 30 to 35. After this presentation, you will be able to take a data collection of your current product that you are already selling, offering to healthcare practitioners that dedicated to kids, and go visit them, because they are the first target group that definitely may be interested in this product, what we are going to present you in few minutes. I want just to say before I give Chris, I give you to lead the presentation, I just want to say that we are starting by kids. As you will see, it's a very easy story to tell, easy story to sell, very convenient. And just to let you know that with the time, we will be providing you more product that will be dedicated to different target groups of your healthcare practitioners. Do you want to add something before we start the presentation, Rama?
No, it's okay. It's perfect like that. I will perhaps make something in conclusion.
Okay, so you will summarize by the end of the presentation. Chris, take the lead.
Okay. So thank you, Oscar. So as Oscar was saying, the concept is how to utilize the DigitsolePro through the life cycle process. And so we're beginning here with children, but to remember that we utilize this throughout the continuation of the life cycle. So a lot of what's going on right now, especially with children, and children was one of the earlier adoptions of utilizing gait analysis in the clinical setting, but it is really complicated. It requires a lot of equipment and very special facilities. And if you don't have those facilities, a lot of what is going on is observational. So the clinicians are only looking at the patients as they walk and trying to gather as much data as they can. However, it's very difficult to see those changes. So one of the things that we've seen from practitioners is looking at the amount of patients in the podiatry space. It's around 10 to 20% of their patient population actually comes from children, pediatrics. And of course, if you specialize in pediatrics in physiotherapy, then you would see a much higher percentage. But in general, we do see a fair amount of those patients, and therefore it would be of benefit to adopt something that allows that. So the child is, as we say, is a bit easy to manage because they will pretty much do what they're asked to perform, but it's the parents that we have to deal with and make sure that they understand what exactly it is going on, as well as what exactly we're trying to do to manage the conditions with their children. So right now, a lot of this data is very subjective. So it means that they don't have the ability to take in that amount of information and be able to qualify it from a technology perspective, or especially quantify it and make it reproducible, make it shareable, make it easily understood so they can provide this information to their patients and to the parents. So right now, it's very difficult to develop a system that gives us this objective data, especially in certain conditions, one of them being the valgus of the foot position in the dynamic mobility, right? So a lot of times people just look at it from a static position, but it's not really providing all of the information necessary to look at that foot position as it's going through the entire foot contact phase. But now we have that opportunity to do so. Also, a lot of the tools that are being utilized are just being retrofitted, meaning that they're for adults and they're trying to create and utilize them for children, but they're not actually adaptable completely 100%. That provides us the best opportunity to get the best information. Lots of patients, lots of parents want to be more involved. They want to know more about what's going on with the children at their level, and we want to be able to show them that information. But currently, right now, it's very observational that the clinician provides to the parents. They don't get to see that information when they take it home. They don't really have a good visual understanding of what exactly is going on. Even when we have some of those details, if they go to a gait analysis laboratory, for example, it's very technical. It can be very difficult to understand. And therefore, the evaluation process really requires a very high level of skill. And to be able to understand that is also something that requires a lot of information. And parents aren't really capable of understanding all of those parameters that we're working with. Also, when we want to coordinate and we want to co-treat, right? So if I'm a clinician and I'm working with another practitioner that is also managing that same case, to provide that level of information is very challenging right now. We don't have the details to be able to provide to the other healthcare practitioners the amount of information and the subjective nature of the dynamic movement patterns to help us work together as a team in treating these patients. And related to that, if we wanted to be able to provide that information, it would normally be done either by hand or, again, it lacks a lot of detail. So the export ability of that information is very challenging because that information is typically not collected in a manner that we can provide a really easy conduit, a really easy pathway to those other practitioners. Even though children tend to be real easy to work with, they're a little bit more challenging because not having the same tools that we might have for the adults, or we have to see them potentially more often because they're changing a lot, right? During their lifespan as a child, we're constantly seeing those changes, and to be able to monitor those changes, we have to see them. So we need to be very efficient. We need to be able to control the amount of time. And so if we're spending too much time in using old methods to not even provide the best information, we're spending too much time, and that loses profitability in the clinic. It keeps me as a practitioner from being able to see other patients. And also, we consistently see that a lot of introduction of insoles and special inserts for adults and especially children, well, they're through that evaluative process that is very visual. So they're not using the appropriate amount of level of detail and information to really provide that sort of recommendation as to the best inserts or insoles, and potentially even the course of care to be able to manage these patients as well as be able to monitor them over their time frame. So the pediatric clinical cases, these are the most common. So the valgus position in the foot. So if we look from the posterior aspect, we look behind the foot and we look at that angle as we're going down the back of the lower leg into where the calcaneus or the heel is. So that's a measure that a lot of times people only look at in a very static position, but it doesn't tell the whole story. It doesn't really allow us to know what's going on as that patient is moving through. Maybe they correct it, maybe they don't correct it. Maybe they move a little, maybe they move too much. And so that too much variability could be indicative. It might be something that we want to know so we can have more information to see the transition of that. And then we have growth problems such as Osgood-Schlatters and Sever's disease, which is, rapid growth and tension in those tendinous structures, and they're pulling away from the bone. Scoliosis and kyphosis and Kohler's disease, very, very common disorders that, again, affect something that we're actually able to measure. Same thing with valgum and varum in the knees and the flat feet. And then also real common is the toe in and the toe out positions that we find in children throughout their growth and development.
I'm here.
Yep. And here's an example of this. And so what is considered to be normal at certain stages of a child's growth pattern is not necessarily normal as the child is growing. And if we could be able to see those things, we might be able to intervene more soon. And that would allow us to keep it from getting to a point where it requires a much greater amount of effort or interventions such as surgical procedures. And so we see this in both the generalist, the family doctor, the pediatrician is often going to be the one to pick up some of these things. or miss some of these things if they don't have the tools to actually be able to see some of those changes and know that those patterns are going to be normal, and then to be able to refer to the podiatrist, who is the specialist in being able to look at what exactly is going on with those feet, and of course maybe even a physiotherapist as part of the overall intervention process. And so having the ability to be able to map out or look at the evolution of a child's condition, it'll help us to understand whether or not what is happening to the child during the growth stages, whether or not it's a pathology or whether or not it's actually a normal process. Okay, so the gait with the structural abnormalities. So the two biggest ones that actually cause this foot position where they toe in, so their toes are pointing towards the midline as they're walking, it's either typically the lower extremity, so where the tibia is, the longer bone that is below the knee, and that's referred to as internal tibial torsion. And it's actually quite normal, especially during the earlier stages, and they're learning how to walk as they're developing the typical gait patterns that allow for those toes to eventually go out, and they have a more normal type of foot stance as they go through the gait cycle. And then we also have the internal femoral torsion. So that's where we actually see the internal rotation taking place at the hip. And so because of the joint position and the femoral head as it connects into the acetabulum, into the pelvis, they create a strategy to where they toe in. So that way they have a more normal position at the hip that can provide a more normal gait pattern, better strength, better coordination. So again, they're very typical that we might see them at the beginning, and a lot of times they can correct, but we want to be able to know that it's not normal. And so having the ability to monitor these conditions can be real important at providing the appropriate intervention so it doesn't progress into a pathology. Okay, so this is a case study, and we're looking at a child with this abnormality. So this is a 10-year-old. And if you look at this gait pattern, that's what's called the corridor on that left side. The green is the normal trajectory as the foot moves through that foot stance, right? So when the foot comes in contact with the ground, we see a typical pattern that the foot should actually go through. We also see the thin lines on either side. And that's the amount of variability that as they strike from step to step to step, we see that degree of variability. More variability is common, especially in the younger children and children in general, because they're always changing their strategies as they tend to grow. So what you see here is it's fairly normal at the beginning as they heel strike, and then they really get into that pronated position, or they force that heel into an outward position as they're going into that toe off. So they're really moving into that toe off position. And this is somewhat common in those toe in positions. And then next we'll look at the gait line, which gives us a little bit more information as to what's going on. So we can see that they heel strike pretty normal, but then we see they transition back over into that pronated position relatively quickly, and they stay on the inside of that foot as they transition into that toe off position. And again, this is pretty common. And if you look at the picture up above, you can see that they're actually toed in, and that would make sense that they're going to provide a lot of that propulsion phase from that toe off position. And then lastly, when we look at this progression angle, so the progression angle is looking at the foot during the swing phase, right? So the other two graphs we're showing is what's going on in contact with the ground, which gives us some really good information for that dynamic foot position when they're in contact and some of their strategies while they're in contact. And then we look at the foot progression angle. So this is looking at the angle of the leg as it's moving through that swing phase. And so a positive angle means that they toe out. And we tend to see a positive angle somewhere between the average of 9 and 15 degrees in an adult. It's a little bit more variable and a little bit smaller in children, but if we think that average of about 8 to 10 degrees. So that would be positive. And as you can see here, not only do we see a negative angle, especially on that right foot, we see a very small angle on that left foot, which means that they're not externally rotating, which is pretty normal as they go through that swing phase. And then also we can see that there's a little bit of deviation where they go into a little bit of circumduction as they move. Again, some of that is fairly normal, but what we do see is there's an asymmetry in the right to the left side as they're moving through that circumduction phase in the swing cycle. Okay, now the evolution and the treatment structure. So this is what I was referring to earlier, and this is what is really important. Is there's a lot of variation we see in children, okay, but what we do know is fairly consistent is they're supposed to go into a fairly normal position as they move through their child life cycle. And so being able to follow that trend gives us a lot of really good, important information to know that they're progressing in a positive direction versus a negative direction. And you can't really visualize that if you're using an observational method. It's very challenging to know the difference between 1 or 2 degrees, or whether or not the patient is starting off in a neutral position and then moving to a -1 over the course of a year, and then into a -2. At least seeing that amount of variation can tell us with the appropriate system that they're not progressing in the direction that should be considered to be normal. And that may indicate that we might want to have some sort of treatment or intervention. So there may be some things that we might want to use, such as utilizing inserts into their shoes to help correct that gait pattern as they're moving through that foot stance cycle, as well as some exercises. So we have tailor or biking position to look at the hip as we're able to look at the flexibility, and we're able to provide some of these types of exercises that could be used for stretching and strengthening. Your basic physiotherapy types of exercises might be required if we pick up this trend evaluation through their pediatric cycle and know if they're going down a pathological path. Okay. Now here's a patient that has an abnormality in that valgus position. So you can see that's the angle, right? If we follow the trajectory of the Achilles tendon as it's coming from the plantar flexors, and then we see that angle position down towards the calcaneus. So that's the angle that we measure to look at this abnormality in this valgus posture. So it's a posture related situation. And so initially this is really common, especially in young children, and actually up to about the ages somewhere between 6 and 10, but we should start to see a progression and that angle actually correct into a normal position as we're moving through. And so again, being able to follow this trajectory through the life cycle could be really important to know whether or not we need to perform some sort of intervention, whether or not there's actually something else going on. Maybe there's a collapsing of the foot arch and we need to intervene and make some changes. Okay, so we see there, we've got two here. We've got a 14-year-old teenager, and then we also have a 12-year-old Chloe. And we see that there are some similarities. And the biggest similarity is that when they do heel strike, and they both do this in both feet, is they heel strike already in a pronated foot position and a heel everted position. And what that means is as they then move through the foot cycle in contact phase, more than likely, they're actually going to continue that path, which means that they're going to overpronate, and that's going to affect their ability to perform an appropriate toe off or perform the appropriate propulsion from the plantar flexors as they move into that swing cycle. And so we can see over here to the left, with the 14-year-old. We also see the trajectory of this 14-year-old in that left foot. So he starts to overpronate, and then he actually gets into a slight supination position. So he has a strategy going on with his toe off that we might want to take into consideration and possibly intervene even beyond what we're seeing with this abnormality with regards to the valgus. The reason that this is also important is this also has a dramatic influence on what's going on at the knee joint and then potentially the hip joint, and another reason why we may intervene. And then we look over to the right with 12-year-old Chloe, and we can also see that she's following a very similar trajectory as we see in that corridor, but she already starts off in an overly supinated position. And then as she is going through the foot stance and getting ready to toe off, we see that she actually goes in a slightly opposite direction. And again, that could be indicative of a potential problem with the foot arch. It could be a knee problem as well. But to know that that's actually not normal is really important, because especially in that 12-year-old, they're starting to reach some level of maturity to where this is going to be their more permanent walking pattern. So we're probably going to want to do something to intervene. You go, yeah, there we go. And so now we take a look at the gait line. So the gait line is the center of pressure, right? So it's the center of pressure as we're going through that contact phase in the stance. And we can see again that this Chloe does start heel striking in that inside, that really pronated position. And then we see she's really riding the medial aspect, the inside of that foot, all the way through that flat foot phase on the left foot, all the way into propulsion. So she's really in that pronated position. And again, that's really going to have an influence of what's going on with her knee. We see it's not as dramatic on the right side, but we do see that, again, she's moving into that pronated position highly consistently. And then we can look at the progression angle. And this is also something that really provides some good information, because sometimes people will compensate and they will swing their legs out really far if they're not appropriately flexing at the foot or the knee or the hip as a strategy to compensate for those changes. We do see that she has a negative angle, which means that she's toeing in a little bit on that side. And that could be one of the reasons that she's actually foot striking in that position. But mostly we see this asymmetry, and a good reason to take that into consideration when we're looking at some of these changes and why we want to make sure that we probably intervene or at least follow her through her cycle. Okay, so the evolution is an interesting statistic that we can get from our system. And I think that's a really important point to look at, because when we think about, as I mentioned earlier, the amount of time that we spend, with patients is crucial. We want to make sure that we spend enough time with patients so we get our point across. So we make sure that everybody understands what the problem is, and we make sure that everybody understands what the intervention should be. So having this evolution and being able to show that trajectory pattern, right, through the cycle, right? So 3 months, 6 months, a year follow-up. It's a real simple visual that the clinician can also show the parents to show the trajectory and the potential changes that are going on with the child, either positive or negative. And that can help us determine whether or not we need to intervene, right? Maybe I'm going to provide some exercises. I might need to refer this patient to another HCP, another practitioner, to assist in that process, depending on who is actually picking this up. A general practitioner may not have the skills necessary to provide the types of exercises or the orthotics, and may refer them to a podiatrist or a physiotherapist. Even though we find that a lot of these children actually do return to normal, because it's a normal process through the growth cycle to see these transitions. But remember that should represent a positive trend. And that's where the evolution provides us the information, so that we know specifically with data and technology that they're actually progressing appropriately. So here are the main parameters that our system tends to identify that is closer related to all of these conditions that we just discussed, and many of the conditions that we see in this pediatric population group. So we've got 25 parameters that our system actually measures, and there's 5 key ones. It's not to remove and say that speed may not be necessary, but specific to these conditions and really things that are challenging to pick up with the eyes, such as the pronation supination angle and the Fick angle, to know whether or not, you know, they're getting into that valgus deformity position that is going to be problematic. The gait line provides us some really good information to show us that center of pressure as they're moving through. And again, with the pronation supination angle, gives us some really good information through that cycle. And then also in that progressive phase, as we showed on the third graph that we identified, the strategies that someone may use if they're not producing the appropriate striking patterns and angles. And then the angle of attack, right? So that's the angle of dorsiflexion that we see. So as you go through that swing phase, you toe off and then you go into dorsiflexion so you can clear the ground, and then you heel strike. And so that angle of attack can be indicative of how far they're walking. Maybe they're producing some strategies to compensate for some of these problems that we've identified. Symmetry is a qualified metric that is simple yet very effective, right? Because we are identifying basically as a symmetrical system from the right to the left, and because locomotion, there's a lot of strategies that are very reflexive that require a lot of motor control. The body naturally tries to compensate and make sure that we do walk in a symmetrical pattern, because that's going to be really important for making sure that that we minimize the potential for injury. So symmetry is looking at the contact phase time between the right and the left, and is one of the first and simplest things that we can look at to identify that something might be going on one side versus the other. So with the DigitsolePro protocol, it's real simple, it's real easy. It allows us to provide a really quantifiable and qualifiable form of information to gather in the office or outside of the office, right? We can put people in their own environment so they don't feel like they're in a laboratory experience. So it provides a real good opportunity to collect data that is very real and useful. The 6 months acquisition in the follow-up walk, so that's looking at those trends, right? So that's the evolution pattern that allows us to collect data that is very detailed and specific, that we can look at either the progression or the regression of a potential pathology, or identify a pathology that might not have been a pathology consideration maybe a year ago. Because it takes so short amount of time, it's easy to provide the test, and the analysis that's generated is also very quick. It's very detailed. It's very understandable. Not only can I show this to the young patients, but also to show it to the parents, because the parents are heavily invested in what is going on with their children, and that brings the better connection, right? So the better the connection with the parents, they're probably going to provide more referrals, and they're more likely to come back to the clinic and probably spend more money on getting treated. All right. Do you want to jump in? You want me to keep going?
Oscar, do you want to jump in on this one, which is the value propositions, or do you? Well, we continue?
You can continue.
I think that Oscar is eating your words.
I'm listening. Yeah. I'm really focusing.
Yeah, I think that Oscar started to be a little bit in love with you in the way that you're delivering the speech.
Let's be clear, not in love with him, in love with the English that he's speaking, like much higher level.
Fair enough, fair enough.
Don't take it personally, Chris.
No, not at all.
Be jealous.
It's the microphone, right? All right. Would you like me to continue, or do you want to jump in, Oscar?
So
Yeah, go ahead.
I think that you are doing it for.
Okay.
If you can do it.
Yeah. So, and this is, you know, I think this is the
assessment. Yeah.
Yes. So the value proposition here is, like we said, we're going through the life cycle. We're focusing on children right now, but to reiterate the fact that it's useful for the entire patient population. And I think the question is, you know, how is that even possible? Well, because locomotion is one of the most basic components, right, to life and thriving. So we look at being able to provide the motion analysis, a dynamic motion analysis for all these different groups and all these different areas throughout someone's own clinical. We see that there's a lot of general parameters. We've got foot kinematics, as well as the advanced settings that provide a lot of information in a really concise manner. The other thing I find, you know, with the system especially, is it brings all of that information. For example, you know, it measures speed and it measures cadence. So it automatically calculates whether or not the cadence is appropriate for that particular speed. That may seem very simple, but to understand that, it's actually a wonderful thing, because it minimizes my time in having to evaluate data, and then I get to spend more time with patients, and it's easy for me to be able to show that. So to be able to work with the children, the adults, and sports and elderly is the continuation that many of us might see within the clinic setting, especially if we don't just focus on one group. So make sure that we understand and emphasize the fact that although we are focusing on just one group now, we will be continuing this message throughout the entire course of the continuum, that this device can actually perform and conduct throughout the entire span of whatever they're going to see. So in that child, you know, the valgus, the growth diseases such as Sever's and Osgood-Schlatters disease, the joint laxities, and as we see, you know, continued information being developed, we already know, for example, with scoliosis, gait is influenced in moderate to severe scoliosis. We didn't even get into, but autism, so people on the spectrum, are also influences their gait pattern. So that's just looking at the child, but remember that we continue throughout the entire cycle of the human growth from adult to elderly, and certainly sports performance. And as I mentioned earlier, to have an output in the analysis that makes it really easy to be able to not only read, but also understand. So we can compare analyses. So I can take two different analyses and I can compare them. But let's say we have this child and we are looking at them over the course of 3, 6 months, 12 months. We can actually look at the evolution. And we get to choose these specific parameters. We can see propulsion speed, we can see average stride speed. So we get to show that over the course of the evolution, which is really important that we don't actually see in most other systems. We are validated, so we know first and foremost that we do collect the data appropriately. And I think that we're the only system that really provides this level of comprehensive kinetic and kinematic data through locomotion analysis. Because the output is very user-friendly, the interface is so simple that I can show it to a patient and they can understand it. Even children, as I show this to children, they visualize what exactly some of these things mean. And that's important, because if a patient understands what's wrong with them, they are more likely to be compliant. As well as when I'm dealing with the parents, remember that they're heavily invested in what is going on with their child. And so being able to explain that information gets buy-in from them. It gets us to bring the parents and make them involved in this process so they can assist us in making sure that the child does actually grow appropriately. So because of all of this, we see a very high degree of motivation, and with motivation comes compliance. And that's a really big challenge in the clinical setting, is getting people to be compliant, right? Because maybe they come into the clinic 2 or 3 times a week for a few weeks, but compliance is more what they're going to be doing at home. The strategies, the interventions that we give them, it's real important that they continue that, because that's where we make a big difference in their overall life, is empowering them and getting them to be compliant and do the things that they're going to be doing at home. We work with other practitioners, so it's real important that it's easy for me to be able to share this information with a co-treating practitioner, so we all see the same information. And because it's so easy to understand, even if they're not a specialist in conservative physical medicine and rehabilitation, it's easy for them to understand, and they know why I'm doing what I'm doing. So we can come up with a plan to really treat these patients with a comprehensive care program.
At the end of the day, what we are providing with all this kind of message, we want the HCP to be perceived, thanks to the data, patient. That's at the point of all this different message that we will be moving through into during the next weeks and months, in order to make sales teams plus HCP much more comfortable in selling the product and in being very comfortable in having all the data. Oscar, I'll give you the end on that one.
Yeah, so, well, what is the DigitsolePro? So today, with the additional kits, small sizes, we have actually 8 pairs in total, starting from 30 to 46. So as you can see, you have 8 pairs, you have interface, you have the mobile, of course, that you can make the acquisitions, and you have the pair of pods that you can put in each insole based
and
on
just
the size
as an information for the team, we will be having also the large size up to 49.
Up to 49. Yes,
exactly. So after that, it's still the same story in terms of easy to use. You have the applications, you insert the insoles, you launch the acquisitions, you are doing the analysis during 1 minute or less than 1 minute time to time. If it's run, we are providing 10 minutes to run, but for work analysis, it's less than 1 minute. You stop the acquisitions when the patient is close to you, you stop the acquisitions, and all the data will be transferred directly to your phone, and also in the meantime to the web interface. So it will be a simultaneous results on your screen, which is wonderful. And just to come back to the last slide, and after that I will give the end to Oscar, just to show you, like Chris already said, and thanks Chris for the clarifications and the message, which is we are going to move through all the patients, all the disorder, to show you all the potentials of the solutions, which is from kids up to elderly people, and also from private clinics to hospitals, to different wards, also to geriatric facilities. So our solutions is very broad. That's why we are now moving to different messages in order to go much more into details and make everyone very comfortable.
So yeah, so basically to summarize, as you mentioned, in order to have like very global approach, we are going in much more details and opening door by door by door. So by the end of the day, if you will take all your healthcare practitioners and between them there are different target groups, for each target group, you will be able to provide different stories based on what they need and based on their current daily activity.
Okay, we are going to send the presentations and the video to all the partners, in order that even partners who did not join, they will have the ability to see and to watch in replay all the video. And tomorrow at 5 p.m. we will be moving to the elderly message, how to address elderly with our solution. And afterwards, within the next few weeks, we will be moving to the sport within podiatrists and the physiotherapist. Thanks, Chris, for your fantastic job, and thanks, Oscar, for your everything. Yes, Oscar, you want?
Just last point, guys. I'm talking to the distributors, of course. Share the presentation with your sales reps, with your people who are in the field, visiting the healthcare practitioners. Share it. Collect questions and come with us if there are some questions. I think now that we have the right approach in terms of how presenting the value proposition of the product and create different stories, now it's important that we will move in the right direction. When there is any kind of question, please don't keep it for you. Share it with us. This is the main goal, that we work together as a team. Okay?
Yep.
Thanks, everyone. Thanks, Rana, Oscar, Christophe, Mikael.
Thank you very much.
Take care.
Awesome.
Bye-bye.
Thank you.
Thank you.
Bye
Take care.
bye.
Bye.
Thank you.